is well documented that iodinated contrast agents used in medical imaging modalities such as angiography and CT affect kidney function. It is generally believed that in most cases the effects are confined to a short period of kidney dysfunction that does not produce symptoms and therefore usually goes undetected. However, it is important to note that iodinated agents can result in significant nephrotoxic effects, particularly in patients who are considered to be at high risk for nephropathy. Given the huge number of contrast media enhanced examinations performed, the nephrotoxic effects are a serious concern. Contrast media induced nephropathy has been reported as the third leading cause of acute renal failure in hospitalized patients. Although often treatable, acute renal failure is a serious complication associated with high mortality. In an effort to better understand the issues surrounding contrast-induced nephropathy, we will look at its definition, including its clinical presentation, incidence, and the factors that place a patient at elevated risk, and summarize strategies that can prevent cases of contrast-induced nephropathy. The term nephropathy technically denotes any condition or disease affecting the kidney. However, it is sometimes used synonymously with renal impairment. Contrast-induced nephropathy, which we'll just call CIN, is an acute impairment of renal function subsequent to the intravascular administration of contrast material, for which all other causes have been excluded. Although a functional definition varies among different studies, the most common measure is a reported rise in serum creatinine of more than 25% above baseline, or an absolute rise of 0.5 milligrams per deciliter within 48 hours of receiving an iodinated contrast agent. Most cases of CIN occur after cardiac catheterization, selective vessel angiography, or contrast-enhanced CT studies. Characteristically, the presentation of CIN is an acute progressive rise in serum creatinine within 24 hours of contrast administration, although this elevation may take up to 48 hours. Serum creatinine levels generally peak at 4 to 5 days, then begin to return towards baseline within 7 to 10 days. Patients with CIN are usually non-oliguric. In most cases, CIN is reversible. However, as in other cases of renal failure, if oliguria occurs, the prognosis is poor. Urinalysis typically reveals coarse granular casts, renal tubular epithelial cells, and amorphous sediment. Hematuria is not characteristic of CIN. Urinalysis may show urate or calcium oxalate crystals. To make the diagnosis of CIN, alternative causes must be eliminated. This is an important step because there are many causes that can trigger pathophysiological mechanisms that can lead to acute renal failure. In the random population undergoing contrast-enhanced imaging, the incidence of CIN is low, generally thought to be between 1 to 6%. However, a number of factors such as renal impairment and diabetes place patients at higher risk of CIN. In high-risk populations, the incidence of CIN can reach up to 50%. Unfortunately, it is frequently this higher risk group that is in need of imaging studies. For the past decade, clinical investigators have focused on identifying patients at higher risk of developing CIN and developing interventions that may diminish the risk of CIN. Although most patients who have CIN suffered little morbidity and recover to near baseline renal function within 7 to 10 days, some patients require temporary dialysis. Even more worrisome, in rare patients, CIN precipitates the need for chronic dialysis. Studies have been conducted substantiating the development of CIN leading to longer hospital stays. In one large retrospective study showed that hospitalized patients who experienced CIN had a mortality rate of 34% compared with 7% in the control subjects, even after controlling for underlying comorbidities. The development of CIN appears to increase the risk of death from non-renal causes such as sepsis, bleeding, respiratory failure, and delirium. The cumulative effect of multiple risk factors increases the risk of CIN has been well documented. In one study that evaluated the effect of 5 factors that included contrast volume, albumin, diabetes, serum sodium, and serum creatinine, CIN occurred in 1.2% of the patients with no risk factors, 11.2% of the patients with one risk factor, and more than 20% of the patients with 2 or more risk factors. Further, when all risk factors were present, the risk of CIN was 100%. Studies have confirmed that pre-existing renal insufficiency is a significant risk factor for CIN. If high osmolality contrast medium is used, even with patients with mild renal impairment, may be at some risk. Diabetes mellitus has long been considered a risk factor for CIN. Although there is some disagreement in the literature, it is generally thought that the diabetic patient with normal renal function is not at a significantly increased risk of CIN. However, a strong association between diabetes with pre-existing renal dysfunction and CIN has been established. Analysis of CIN in patient groups studied yielded the following results. Diabetes and normal renal function, 0.6. Renal insufficiency alone, 6%. When you combine diabetes and renal insufficiency, 19.7%. Although patients with diabetes and normal renal function should be evaluated carefully, most appear to be fairly low risk for having CIN. However, patients with diabetes and pre-existing renal insufficiency represent a group with an extremely high risk of experiencing contrast-induced nephropathy. Several studies have revealed a direct correlation between the volume of contrast administered and the risk of CIN. Therefore, procedures that require a higher volume of contrast material, such as a selective vessel angiography, place a patient at a higher risk. In CT, it's not unusual to administer more than 200 mL of IV contrast to a single patient. However, when this is to be considered, the renal status of the patient will be an important consideration. It is well accepted that patients who are dehydrated before an imaging examination have an increased risk of CIN. Although multiple myeloma has traditionally been regarded as a risk factor for CIN, many researchers now believe that the risk is primarily related to the dehydration of the multiple myeloma patient. Several other risk factors have been investigated with no clear consensus at present as to whether they represent an independent risk factors for CIN. These factors may include patient age, patient sex, and atherosclerotic disease. Unlike most forms of hospital-acquired acute renal failure, CIN is amenable to preventative measures. Newer research has provided an increased understanding of the pathogenesis of CIN and the critical roles of renal vasoconstriction and medullary ischemia. This knowledge has resulted in the proposal of several prophylactic approaches. Nephrotoxic effects of contrast media are likely caused by chemotoxicity and osmolarity. The viscosity of the media may have a role, but this hypothesis is currently unproved. It is well recognized that older, high osmolarity contrast medium is associated with a higher rate of nephrotoxicity than is the newer, lower osmolarity contrast media. At least 2 studies have indicated that for high-risk patients, isomolar contrast offers even more protection from CIN than does lower osmolarity contrast media, although other studies state that osmolarity agents confer no protection. It has been well documented that hydration decreases the incidence of CIN. On the basis of numerous animal and human studies, it is recommended that all patients receive oral and IV hydration at the time of a contrast-enhanced procedure. Patients at risk for CIN should receive IV fluids before and after imaging procedures. As we talked about earlier, CIN is dependent on the dose of contrast material used. Therefore, the smallest amount of contrast possible should be used for each procedure. In some cases, enhancement profiles may be improved with the use of a saline bolus after the contrast injection, resulting in the reduction of contrast required for a given study. Allowing at least 48 hours to lapse between procedures in which contrast material is used enables the kidneys to recover. Many medications are associated with the development of acute renal failure. When a contrast-enhanced examination is scheduled for a patient at risk for CIN, the patient's physician may wish to temporarily discontinue these medications. Non-steroidal anti-inflammatory drugs and antiplatelet agents are two examples of nephrotoxic medications. By following some simple preventative measures, you can greatly reduce the risk to your patients from acquiring CIN and the further complications that can result from that.